Good afternoon everyone. I am presenting a case report of toxic epidermal necrolysis. A 35-year-old female came with a chief complaint of painful erythematous rash all over the body and decreased vision since 5 days. The rash is sudden in onset, gradually progressive and painful in nature. The patient had a history of taking NSAID per oral 2 days before the onset of symptoms for headache. No history of diabetes, hypertension, thyroid, tuberculosis, coronary artery disease and cerebrovascular attacks. No history of allergies. On examination of the patient, multiple ill-defined erythematous purpuric macules of irregular size and shape which are painful are seen all over the face, body, both upper and lower limbs associated with peeling of the skin. On ocular examination, the visual acuity in the both eyes is counting fingers 2 meters. On examination of the anterior segment in slit lamp, the eyebrows are covered by scab in both eyes. On examination of eyelids, raw areas with fresh bleed due to the sloughing of the skin is seen, and the adhesions between the upper and lower eyelid margins are seen. Eyelashes are absent. On examination of conjunctiva, there is congestion with mucopurulent discharge and adhesion between the palpebral and bulbar conjunctiva. Cornea, there are large epithelial defects with fluorescent stain positive. Anterior chamber appears hazy due to the corneal epithelial defects, and iris, pupil and lens are hazily seen. These are the images at the time of presentation with the sloughing of the skin on the eyelids, and eyebrows are covered by the scab, and these are the raw areas with fresh bleed. The patient is treated with preservative-free lubricant eye drops hourly and preservative-free lubricant eye ointment 4 times a day, and prednisolone 1% drops 12 times per day are used in a tapering manner for 6 weeks duration. Moxifloxacin 0.5% eye drops is given at 6 times per day, and adhesive lysis is done with sterile glass rod daily. These are the images after 8 weeks of the treatment with the healed lesions, and epithelial defect is healed with the clear cornea, and the vision is improved to 6/6 after 8 weeks, and we can see minimal adhesions between the palpebral and bulbar conjunctiva, and between in the lateral canthus and the medial canthus, adhesions between the upper and lower eyelid margins. These are the images which we can see after 3 months of the treatment with minimal adhesions between the upper and lower eyelid margins. Discussion. Toxic epidermal necrolysis is an acute inflammatory vesiculobullous reaction involving skin and at least 2 mucous membrane. This incidence increases with age and is more in HIV patients, with mortality rate of 25 to 35% due to sepsis. Most of the cases of toxic epidermal necrolysis are drug-induced. Drug-specific cytotoxic T lymphocytes produced by perforin granzyme pathway enter target cell and induce apoptosis of the keratinocyte. Latent period between intake of culprit drug and onset of the symptoms is 7 to 10 days. TN is characterized by massive denudation of the epidermis. Extensive epidermal detachment leads to a series of homeostatic dysfunction leading to the acute skin failure. Ocular findings can be acute and chronic. Acute symptoms include non-specific conjunctivitis, which occurs at same times as lesions on skin and mucous membrane. These lesions usually resolve within 2 to 4 weeks, and the severity grading was determined on the scale from 0 to 3, which include none, mild, severe, very severe. Chronic findings include inflammatory process which may lead to symblepharon, ankyloblepharon due to raw necrotic conjunctival surface. Tear film instability due to the loss of goblet cells, which cause chronic irritation of cornea, which can lead to persistent epithelial defects. Scarring, entropy and trichiasis can also occur. Dry eye is significant problem secondary to scarring of ocular surface, which can be treated by lubrication punctal occlusion. Loss of epithelial barrier increases the risk of infection. Complications are characterized under 3 headings: eyelid, conjunctival and cornea. Eyelid complications include trichiasis, mucocutaneous junction involvement, meibomian gland involvement and punctal damage. Conjunctival complications include hyperemia and symblepharon formation. Corneal complications like superficial punctate keratopathy, epithelial defect, loss of palisades of Vogt, conjunctivalization, neovascularization, opacification and keratinization. It is managed by ocular surface hygiene, conjunctival irrigation, installation of preservative-free antibiotics as prophylaxis to prevent secondary bacterial infections, preservative-free artificial tear supplements. Even the use of topical steroids is controversial due to the risk of infections. In this case, we started 1% prednisolone eye drops within first week of onset of symptoms, which prevented dreadful vision loss and ocular threatening complications. Daily lysis of adhesions with a sterile glass rod is to be done even though they can reoccur. Thank you.
This? It was secondary to an NSAID, right?
Yes, ma'am. She gave a history of she took paracetamol, ma'am.
So what's the incidence of TEN, secondary to paracetamol? Like how common is that?
8 cases per 1.5 million, ma'am.
So you have given a time frame of 7 to 10 days as latent period, isn't it? This
But
was
this
like after 2 days.
after 2 days.
So how did you establish the causality of paracetamol to this?
Patient said nearly 3 to 4 weeks.
Paracetamol is one of the safest drugs, isn't it?
But she gave history of paracetamol.
She used the paracetamol for 3 to 4
Yes,
weeks.
ma'am. They showed a strip also, ma'am.
Alone or in combination with something?
Alone.
Okay. All right. Thank you.